अंदाजा हो जाए जी।
अस्सलाम वालेकुम डॉक्टर फाइज।
जी
अस्सलाम वालेकुम
वालेकुम।
डॉक्टर आयशा, क्या हाल है? ठीक ठाक?
जी अस्सलाम वालेकुम, ठीक ठाक बिल्कुल।
और
आप
मुजाहिद
ठीक
साहब वेलकम।
थैंक यू सर, थैंक यू।
क्या हाल है सर? ठीक ठाक, खैरियत? पेशावर आप आए थे, आपको अगर याद हो,
जी
वो
बिल्कुल।
टेम्पलेटिंग की वर्कशॉप हुई थी, उसमें आपसे मुलाकात हुई थी।
ऐसा ही है, ऐसा ही है।
अच्छा, वेलकम डॉक्टर हुसैन।
डॉक्टर अपना माइक
हुसैन जो
अनम्यूट कर
है
लें।
वो उन्हीं का हम वेट कर रहे हैं जी। अच्छा आ गए जी, नजर आ रहे थे। काइंडली आप अपनी एक दफा स्क्रीन शेयर कर लें ताकि हमें हो जाए जी। आपने अपने आप को अनम्यूट भी करना है डॉक्टर हुसैन।
अस्सलाम वालेकुम। वो स्क्रीन शेयर का ऑप्शन होस्ट की तरफ से डिसेबल्ड है।
अच्छा
जी दे
वो
दिया है
कर
आपको।
देते
जी दे दिया।
हैं।
इरफान साहब वेलकम।
अस्सलाम वालेकुम। फैज
क्या
साहब
हाल है
ठीक ठाक है
सर?
आप?
सर वेरी नाइस टू हियर फ्रॉम यू सर। थैंक यू
थैंक
सेम
सर।
हियर।
थैंक यू।
सेम हियर सर।
इसका क्रेडिट हुसैन साहब को जाता है। मुझे कल से परसों से कह रहे हैं सर ये आर्टिकल लें, ये पढ़े। मेरी आर्टिकल जो है वो जनरल क्लब में डिस्कस होगा, तो मैंने फिर रात को बैठ के उसको मजबूरन पढ़ा।
लेकिन सर
थैंक यू सर।
सर लेकिन पोस्टमार्टम नहीं करना है,
तो
आर्टिकल का
जनरल
पोस्टमार्टम नहीं करना है सर।
जनरल क्लब तो होता ही पोस्टमार्टम के लिए है।
वो तो मुजाहिद साहब ने करना ही करना है। अगर सर नहीं भी करेंगे तो मुजाहिद साहब तो फुल वहाँ आए हैं प्रैक्टिस करके।
नहीं, मुजाहिद साहब तो अपना पोस्टमार्टम तो कोई नहीं कर सकता ना, और लोग करते हैं।
ये भी बात ठीक है सर।
जो सब्जेक्ट होता है वो अपना पोस्टमार्टम थोड़ी कर रहा होता है।
ये भी है सर, वो तो कवर करने की
नहीं
कोशिश
नहीं,
करेंगे।
इट वाज अ वेरी वेरी गुड इंफॉर्मेटिव आर्टिकल। मैंने पढ़ा है रात को, तो मैंने बहुत
जी
कोशिश की कि इसमें कोई नुक्ते निकालूं, लेकिन नहीं मिले मुझे कोई ज्यादा।
ठीक ठीक। तो चले सर, मेरे ख्याल से टाइम जो है 9:05 हो गए। तो साद मैं थोड़ा सा पहले ब्रीफ कर देती हूँ जो हमारा पैटर्न होता है। ये हमारा बेसिकली 10th JPOA का वर्चुअल जनरल क्लब है, and it's a really good initiative especially for young surgeons and consultants and researchers, क्योंकि mostly we are promoting research which is done locally और जो locally हमारे JPOA में publish होती है। तो इसमें for the first 20 to 25 minutes डॉक्टर हुसैन वहाब जो हैं वो अपनी प्रेजेंटेशन देंगे। देयर इज अ सेट फॉर्मेट जिसपे उन्होंने अपना आर्टिकल पूरा फॉर्मेट किए, एंड फॉलोइंग दैट जो डॉक्टर मुजाहिद जमील हैं, ही इज आवर एक्सपर्ट फॉर टुडेज सेशन। तो वो इसके ऊपर अपने एक्सपर्ट कमेंट्स देंगे, एंड मीनवाइल वी विल आस्क द ऑडियंस कि वो चैट बॉक्स में अपने क्वेश्चंस डालते जाएं, और एंड में वी विल हैव अ क्वेश्चन आंसर सेशन एंड वी विल एंड एट 10 AM. सबसे पहले I will request Saad to kindly play a few verses from the Holy Quran, and so that we formally start our meeting. في السماوات وما في الأرض وإن تبدوا أنفسكم أو تخفوه يحاسبكم به الله ويعذب من يشاء والله على كل شيء قدير. بالله من الشيطان الرجيم. بسم الله الرحمن الرحيم. لله ما في السماوات وما في الأرض وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير.
آمن الرسول بما أنزل إليه من ربه والمؤمنون كل آمن بالله وملائكته وكتبه ورسله لا نفرق بين أحد من رسله وقالوا سمعنا وأطعنا غفرانك ربنا وإليك المصير لا يكلف الله نفسا إلا وسعها لها ما كسبت وعليها ربنا لا تؤاخذنا إن نسينا أو أخطأنا ربنا ولا تحمل علينا إصرا كما حملته على الذين من قبلنا ربنا ولا تحملنا ما لا طاقة لنا به واعف عنا واغفر لنا وارحمنا أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين أنت مولانا فانصرنا على القوم الكافرين.
Jazakallah. Over to you, Dr. Aisha.
Jazakallah. So welcome everyone. Assalamu alaikum to the 10th Virtual Journal Club of Pakistan Orthopedic Association. So it's an ongoing initiative to encourage research, publication and research conduct locally in our country, which is being published in JPOA. And we are really happy that today Dr. Hussain Wahab's original article is going to be discussed. It's on the etiology of total knee arthroplasty failure and functional outcome of revision knee arthroplasty. We are really pleased that today as an expert, we have Dr. Mujahid Jameel, who's the chair of Pakistan Arthroplasty Forum. And so I will request Dr. Hussain to kindly unmute himself and share his screen. And we will listen to him for the first 20 to 25 minutes. And then the audience can post their questions in the chat box. And we will also hear from our respected senior participants that have joined. So over to Dr. Hussain.
Assalamu alaikum. I'm Dr. Hussain, working as Senior Registrar Orthopedics at Northwest General Hospital, Peshawar. I will be presenting monthly JPOA Journal Club. The topic of my article is etiology of total knee arthroplasty and its functional outcome of the revision total knee arthroplasty. Authors of this article are Hussain Wahab. I'm working at Northwest General Hospital. Dr. Talal Akil, who is working at Worcester Acute Hospital Trust UK. Amar Abbasi, final medical student at Aga Khan Medical College. Dr. Junaid, Chief Resident at Aga Khan University Hospital. Dr. Mujahid Jameel, Dr. Masood Umar, and Dr. Parvez Hashmi. All of them are consultant at Aga Khan University Hospital. It was published in Journal of Pakistan Orthopedic Association, which is recognized by Higher Education Commission and Pakistan Medical Commission, and it is indexed by the ScoopMed, PacMedinet, Google Scholars, and Eurasian and IGI. The target viewers of this journal are orthopedic and trauma surgeons, plastic surgeons, spine surgeons, physiotherapists, researchers, and residents of the orthopedics and plastic surgery, medical students, and healthcare professionals. So as we know, total knee arthroplasty is a very efficacious and cost-effective intervention for the advanced stage of osteoarthritis in terms of alleviating pain and also improving function of the patients. So the total knee arthroplasty is very common these days, and it is one of the most common orthopedic procedures performed worldwide. Increase in the total number of total knee arthroplasty has also increased to its complications. So the revision total knee arthroplasty increase is due to some factors, which are due to modification in the surgical techniques. Overall, the general population life expectancy has increased, and The patient, the inclusion criteria for the patient has also increased. So total knee arthroplasty is also nowadays performed in younger patients who are more active, so which leads to more complications. The outcome of revision knee arthroplasty is also dependent on the reason why the primary total knee arthroplasty failed. So we need to know the exact reasons before going for revision knee arthroplasty. And the common causes mentioned in the literature are aseptic loosening, infections, polyethylene wear, or instability, or sometimes stiffness. So in order to rule out, as there was no local study published on this data, so we wanted to know the local demographics of the patients, what are the common causes of the primary arthroplasty failure, and what are the functional outcomes of the revision arthroplasty in our regions. So the target population was all those patients who presented to Aga Khan University Hospital with total knee failure requiring revision total knee arthroplasty, and whose surgery was done within last 10 years. Intervention was revision of total knee arthroplasty. There was no control group, and the outcome measures were causes of arthroplasty failure and pre-op and post-op WOMIC score for the knee function. Before going into the details of the article, we reviewed literature which is presented here. This was the first article which was published in 2001, early failure causes in total knee arthroplasty. And this total number of patients were included 450, and it was a retrospective study from 1986 to 1999. The most common cause of total knee arthroplasty failure in their study was infection, instability, and the least common cause was aseptic loosening, which was only 3%. Then another study was published in 2004, that is the patient outcome following revision total knee arthroplasty. It was a meta-analysis. So all the original articles published from 1990 to 2002 were included. Total 33 studies were met the inclusion criteria, and 1,356 patients were included. The preoperative score was 49 knee society score, and post-op knee score was 84. So there was significant improvement in the revision knee arthroplasty. In their study, the most common cause of failure was loosening, polyethylene wear, and infection was the least common cause. Then another study which was published in 2007, that is the functional improvement after total knee arthroplasty revision. So in this was also a retrospective study. Total number of patients was 186, and there was equal representation of male and female gender, and there was significant improvement at 6 months follow-up. They also mentioned WOMIC score in their study, which improved from 9.9 to 5.6 for pain, for stiffness from 4.1 to 3.1, and for function from 33 to 21. So there was significant improvement in the WOMIC score. Another study was published in 2013. This was also a retrospective study, and total 41 knees were included. The most common cause in their study was aseptic loosening, which was 31%, and periprosthetic fracture was the least common cause. Infection was the third common cause in their study. Okay, they also did knee society score. Pre-op it was 28, and post-op it improved to 77. So they included both the etiology and also the functional outcome in revision total knee arthroplasty. In 2014, another retrospective study was done. They reviewed 256 total knee arthroplasty revisions. The failure rate was 7% in patients who were younger than 55 years, and it was less common in patients who were more than 55 years. And they mentioned that the cause of the failure was because these patients were more active. So the more active lifestyle leads to early failure. And in their study, polyethylene wear is the most common cause. Infection was the second most common cause. Okay, in 2017, causes and clinical outcome of revision total knee arthroplasty was published. And this, they retrospectively reviewed 225 revision total knee arthroplasty. Septic complication was in 58% cases, and aseptic complication was in 41. Aseptic complications were, they included periprosthetic fractures, loosening, polyethylene wear, and instability. Periprosthetic fracture was most common in the aseptic complications. So in our study, the study design was descriptive study, which was a retrospective cross-sectional study. Duration was from January 2010 to December 2020, and location was all those patients who presented to our Khan University Hospital for the revision of total knee orthoplasty. The study was approved by the ethical committee of our hospital. The inclusion criteria, all those patients of either gender and age who were operated for the total knee orthoplasty due to osteoarthritis within last 10 years, and they presented to us with some complications which needed a revision total knee orthoplasty. Morbidly obese patients were excluded from our study. Okay, details of the data collection. This is the limitation of the study. Details of the data collection are not very well elaborated because it was a retrospective study, and all the data was retrieved from the files or data saved on computers. All those patients who underwent revision total knee orthoplasty, they were given supervised physiotherapy, and all patients were reviewed at 6 months follow-up. Outcome in terms of etiology of total knee was also retrieved from the files, from the initial presenting history and the labs. And outcome in terms of functional outcome was assessed on WOMIC score at 6 months follow-up. And it was also calculated on presentation at the time of admission. This is for the residents, how the WOMIC score is calculated. It has 3 components: pain, stiffness, and physical function. When the pain is more extreme, so you give number 4. If there is no pain, you can give number 0. The preoperative and postoperative WOMIC score was compared, and p-value was calculated. P-value less than 0.05 was significant, and data was analyzed using SPSS with the help of a statistician. Results. So the results are clearly mentioned in the article. Total number of patients was 29 with 33 knees. The mean age was 60 years plus minus 6 years. The female to male ratio was 25:4, and the 4th patient had bilateral total knee revisions. And the interval between the primary and revision total knee orthoplasty was 48 plus minus 4 years, which is around 4 years. So etiology of failure, infection was the most common cause in our cases, which was 45%. Aseptic loosening occurred in 14 knees, which is 42%, and periprosthetic in 4 patients, which is 12% of the total. Types of implants used for revision total knee orthoplasty: only augmentation was done in 36, constrained condylar knee prosthesis in 33, and rotating hinge orthoplasty was used in 24. Wedging and augmentation both in 1 knee, and distal femur plate was used in only 1 patient. The outcome results of revision total knee orthoplasty: WOMIC score was calculated. For pain, it improved from 18 to 2.2. For stiffness, it improved from 8.7 to 3.4, and the functional score improved from 72 to 10.4. There were also some complications in our cases. 1 patient had extensor mechanism injury, 1 had lateral collateral ligament, and 1 had femoral condylar fracture. So this was 3% of the total. Okay, this table compares the international data done in our. So the first was in 2001, who included 40 patients retrospectively, and the most common cause in their failure was infection, and the least common cause was aseptic loosening. They did not comment on the outcome. Sharkey et al. Presented in 2002. That was a 3 years retrospective data. 212 patients were including. Polyethylene wear was the most common cause in their case. So it has reversed, and infection was the least common cause in their study. In 2003, 122 patients retrospective were reviewed, and then the polyethylene wear was the most common cause. Then in 2004, a meta-analysis was done in which 1,356 patients were including, and this was a large data. The most common cause was loosening, which was 55%, and infection was the least common cause. And knee society score, they also commented on the outcomes. So the knee society score improved from 49 to 84. In 2007, another data was published mainly based on the outcome of the revision total knee orthoplasty. So the WOMIC score, pain improved from 9.9 to 5.6. stiffness from 4.1 to 3.1. Sorry, there is a mistake in writing. It improved to 3.1, and function improved from 33 to 21. Okay, there was another retrospective study from 2006 to 2011, which was published in 2013. And their study, mechanical loosening was the most common cause, and the second most common cause was infection. In 2003, Tay et al. Reviewed 41 knees retrospectively, and aseptic loosening was the most common cause. They also mentioned on the commented on the outcome. The knee society score improved from 28 to 77 at 6 months, and also at 2 years they calculated, which was 77.6. In their study, infection was the second most common cause. Kim et al. Published a study of 256 revision total knee orthoplasty. It was also a retrospective study from 1992 to 2012. And polyethylene wear was the most common cause. Infection was the second most common cause in their study. In 2017, 225 revision total knee orthoplasty were reviewed, and septic complication was the most common cause, which was 58%. In 2019, a systematic review was done. The mean revision rate was 7% in morbidly obese people, and it was 2% in non-obese people. So obesity is also a reason for the primary total knee orthoplasty failure. In our study, we reviewed total 33 knees. It was a retrospective study. Infection was the most common cause, which is 45%, and the VOMIC score improved significantly at 6 months follow-up. Limitations of our study is it is a retrospective study and very simple, small sample size. The strengths of our study is it is the first study in the local region to determine the etiology of revision orthoplasty, and also to look for the outcome of the revision knee orthoplasty. And we also compared our data with the international study, which is consistent with them. As there is increase in the total knee orthoplasty, and subsequently there is also increased need for the revision knee orthoplasty. So there is, due to significant improvement in the surgical techniques, the aseptic causes of the total knee orthoplasty failure have reduced, and infection is the most common cause. Revision knee orthoplasty is a difficult job, but overall the results and functional outcome are very good. So it is recommended to conduct a prospective study with a large sample size, with a control group and randomization. The study of the revision knee orthoplasty should teach us how to improve primary total knee orthoplasty and its durability. Thank you.
Okay, so thank you very much for a very comprehensive presentation, and especially the review of literature that you have done. So now I will, we are glad that today we have a lot of senior people from Pakistan Orthopedic Association who have joined us. So first we will move to our expert, Dr. Mujahid Jamil, who is also a co-author on this article. He is the chair of the Pakistan Orthoplasty Forum and a consultant arthroplasty surgeon at Aga Khan University Hospital, Karachi. Dr. Mujahid, over to you for your expert comments.
Assalamu alaikum, Aisha. I congratulate you on persistent and very productive activity of this Journal Club of Pakistan Orthopedic Association. अभी थोड़ी देर पहले राजा इरफान कादिर साहब से मैं कह रहा था कि आपकी जो है तस्वीर नहीं आ रही। मैं सर ईद मोहम्मद साहब को सलाम करना चाहता हूँ कि इनकी तो ना तस्वीर आ रही है ना आवाज आ रही है। सर किधर हैं आप?
जी सर।
अस्सलाम वालेकुम सर। आप लिफ्ट देंगे तो तस्वीर भी आएगी, आवाज भी आएगी।
सर तो आपकी तस्वीर क्यों नहीं आ रही? आवाज तो अभी चलो आ गई सुनने को। वालेकुम सलाम।
तो ये तो पता नहीं मुझे, या आप लोग बताएंगे कि मेरी तस्वीर क्यों नहीं, मुझे एहतजाज करना चाहिए।
चलें, आपकी आवाज सुन के बहुत अच्छा लगा। उम्मीद है आप खैर खैरियत से होंगे।
थैंक यू वेरी मच, थैंक यू वेरी मच।
अच्छा, before I start commenting, Dr. Raja Irfan Qadir appears to have been overwhelmingly involved in this presentation. He was saying that Dr. Hussain has been putting a lot of pressure on him to be here. So I would like him to express his views on how it is. Sir, Dr. Raja Irfan Qadir.
Assalamu alaikum, everybody. Thank you very much, and thank you for your asking me to comment my views. First of all, I'll congratulate Dr. Aisha Saeed for this continuous educational activity for the seniors as well as for the juniors. Yes, Hussain has been asking me to attend this webinar, and I must congratulate him and his team on this wonderful paper, which is very informative. And as I said earlier, I have been going through this article last night and couldn't find any big flaws, although there might be a few questions raised, but I think that is the limitation of the study because it was a retrospective study and data collection from the patients for the last 10 years is always not possible as one would wish for. Thank you very much, and I'll be waiting for your comment because you have been a co-author in this article and would like to know what were the difficulties. I'm sure you would be documenting the WOMAC score for all the patients. Otherwise, it would have been not possible to compare the pre-op and post-op scoring. Thank you.
Ji, thank you very much, Dr. Raja Irfan Qadir. I tell you that whenever we see an article, there are two things about it. One is to critically analyze the article and its scientific content. And the other aspect is what do we learn from this article and how will we change our practices as a reflection of that. So I personally tend to focus, especially for the trainees and budding orthopedic surgeon and myself as well, as to what I have learned from the experience of this article, whether it's mine or somebody else. So I think Hussain is the key person here. He has flooded us with complex knowledge of a complex revision problem in knee surgery. And he may be the best person to reflect first as to what has he learned from this article and how would he change his practice of knee surgery after reading all of this. Hussain, can you say anything in short term, in simple, jise kehte hain khulasa?
Sir, first of all, the revision orthoplasty is not a simple revision of the primary knee. So before going for the revision orthoplasty, we should rule out all the possible causes which lead to this condition. The second is, as Dr. Irfan mentioned, most of the time we do not mention WOMAC score pre-op and post-op operatively. In AKU, there is a nurse who is assigned for this, who post-operatively assess this, but we should develop this practice so that whenever the patient comes to us for the revision, we should know how his functional status has deteriorated.
Yeah, right. So you see, revision is a big consideration. Revision knee is a very, very big consideration. It has psychological, physiological, and financial huge impacts. And therefore, the decision is a big decision to revise a knee. I'm sure Dr. Irfan Qadir and other seniors who are here can feel what I'm saying. So one should really look into the cause of it. Okay, why do we need to revise? And if you look to all the articles that you've presented, the most common or one of the leading cause is infection. So what I'm going to say is actually reflecting on the article and practice both, is that once you see an infection, you should be very inquisitive of the fact that how we got this knee infected, and should explore all the options which can be rectified before we revise the knee. So those are patient-related factors, those are surgeon-related factors, and possibly a little bit up to implant-related factors in terms of sterilization and processing. So there are few factors that we can control, and there are few factors that we can't control. So patient-related factors cannot be controlled because patient has got what they have got in terms of diabetes, obesity, or anything. The only thing that you can control in terms of patient-related infection factors is if they have a remote infection, and you can treat it appropriately before you embark on any further surgical intervention. But the other things can't be controlled. But what is important is you can identify what patients are at high risk, even for a primary knee arthroplasty, and then you can take some extra measures to minimize the risk of infection, because infection is a disaster. The problem with the infection is that you can't get away with it before you take the whole implant out once it is settled in 4 to 6 weeks down the line. We should try to identify a high-risk patient in every single primary knee arthroplasty that we do. And there is a lot going on in terms of preventing and treating infection. The newest technique which has come into show is intraosseous infiltration of antibiotics into the knee, even in primary knees for high-risk patients. This is probably the recent most technique which has come into practice, and there are papers there. And we are seriously thinking of running a prospective trial of injecting intraosseous antibiotics, i.e. distal femur, proximal tibia, into patients with high risk. I mean, risk patients with diabetes, patients with morbid obesity, and patient in a slightly immunocompromised status like rheumatoid arthritis, so that we can minimize the chance of infection. So identifying the patient risk factors for infection and trying to do everything is important. Second is polyethylene wear and instability. So those are the factors that you can also minimize by using highly cross-linked polyethylene and avoiding gross malalignment. Now, gross malalignment is one of those factors which usually do not happen, but what does happen is instability in the range of flexion. This is more common, and which is difficult to identify perioperatively because it's a dynamic problem, and it comes into play when the patient starts to really walk on it. Otherwise, we just tend to sort of see flexion, extension, balancing and all that, which does reflect it up to a little extent, but does not reflect in actual sense when the patient is about to walk on it. And the patients who have poor proprioception, lack of neuromuscular control, inappropriate physiotherapy, weak quadriceps, some problem in the spine, some problem in the back, plus a little bit of instability, will eventually come to your clinic 2-3 years down the line, 4 years down the line, with rapid polyethylene wear and a failed total knee arthroplasty. So the article itself is okay. It's not a huge number, but given the financial circumstances, and as I said, the decision to embark on revision knee arthroplasty, not only on the behalf of surgeon, but also on the behalf of the patient, is very, very difficult. So you might have seen a lot of patients hanging around with problems of sort of unhappy total knee, but lingering on because they can't just take the decision of having it revised because of financial, social, and physiological implications. So the article is actually showing us what I can say is the bad phase of total knee arthroplasty, which is a very good operation to do. But if it goes wrong, then the implications are disastrous and very difficult to control.
I think Dr. Faiz wants to make a point here. Ji, Dr. Faiz.
Thank you, Aisha. I welcome Professor Eid Mohammed, President, Pakistan Orthopedic Association. Welcome, sir. My question is from Dr. Mujahid and from Professor Raja Irfan Kader. I have just a query. Keeping in mind all other factors for revision, if we take the age, so my question is that fear of revision, can this fear of revision at a younger age patient, when there is an indication for primary total knee, can this be, justified for avoiding this total knee in younger age patients? I mean, if we do this total knee arthroplasty primary, we can we can wait the good quality of life to him for say for 6-8 years. Can this be justified that we deprived him of this just because fear of this revision?
Thank you, Faiz. May I respond with permission of Dr. Aisha?
Yes, sure, sir.
A very good question raised, because it's a dilemma when a patient in his 50s, maybe early 50s, or maybe late 40s, comes to you with a bad knee. It becomes very difficult to decide whether one should wait and for him to continue his sort of say compromised life, or shall we intervene at this stage. Now, as you have seen from the studies mentioned by Dr. Wahab, that revision rate of the patients who are less than 55 years is about 7% in different studies, although it varies. And if if you see the revision rate in patients with more than 55 years of age drops to 2%, around 2%. So once you see the patient, we have to discuss this in detail, keeping in mind what is his activity level, how bad his knee is. I mean, the knee may be looking very bad on the X-rays, but if you ask the patient, he may not be say disturbed with his social life, his economical life, may not have the same sort of level of compromise as it looks on the X-rays. So if you ask the patient, you can live with it for maybe 4 or 5 more years, but it is between you and your patient. You have to explain to the patient that if we do it early, there are chances that we will end up in revision. And revision surgery, as mentioned by Mujahid Saab, is not a simple task. It is a very difficult procedure, and not all the orthopedic surgeons are doing it. So it is a decision to be made between the patient and the doctor treating the surgeon, and his, of course, functional compromise at that particular point. I personally, actually, I am personally a very conservative surgeon in this regard, and I convince the patient, if they can live with it without much agony, then probably it's best to wait as long as they can. But sometimes it's not possible. But he has to understand that the earlier he has this knee replacement, and for that sake, any joint replacement, he will have more chances of going into a revision surgery. Thank you.
Yes, yes, very valid point, Irfan sir. And Dr. Mujahid Jameel, do you want to add on this point?
Yes, I do. A very good point raised by Dr. Faiz. My response to this question would be to critically analyze the symptoms. So by that, I mean, a lot of these patients, when they are in their late 40s and early 50s, would have degenerative symptoms from sources that are not cartilage related. For example, a torn meniscus. And these patients can have sharp, painful episodes because the meniscus is still in not the age as a young meniscus would be, but it is still stiff enough to create a lot of symptoms in the medial compartment and sometimes mechanical symptoms. So you have to critically analyze this to exclude other causes and look for windows of opportunity to do something less than a total knee replacement. So these patients might have a torn meniscus, which is catching in and out in their routine because they're active in their late 40s and early 50s. And sometimes you can just do an arthroscopy and get a symptomatic relief for a reasonable period of time, like 6 months, 1 year, 2 years, 3 years. The other is symptoms from other sources, like hip is a common cause, and also the back is a common cause. And then further analysis into the symptoms of the knee in terms of which compartment it is. So as we know, all of us know that 75 to 80% of the weight bearing axis and the weight comes through the medial compartment. So there would be at least 30-40% of these patients who would have predominantly medial compartment symptoms. They are not as common as tricompartmental patients, but some patients would have medial compartment symptoms. And if you can see on X-ray that only medial compartment is worn out, with less sclerosis and osteophytosis in the lateral compartment and the patellofemoral compartment. And you can also clinically judge that PFJ is not the source of symptoms, there is no tenderness in the lateral compartment, then you can possibly consider them or refer them to somebody who can do an isolated unicompartmental knee arthroplasty, which is a good option for these patients because it can survive good 6 to 10 years. And then you can do a primary total knee arthroplasty when they are in their early 60s or late 60s, rather than you do a total knee arthroplasty and then you're looking for a total arthroplasty 10 years down the line. So you need to philosophically think as to how can you preserve the bone stock of the patients by first considering minimally invasive interventions. If you can see that there is a possibility of symptomatic relief by doing a simple arthroscopy, or then you can also consider conservative. These patients come for you for a revision compartment rather than a primary total knee arthroplasty, because in an orthosurgeon you can see just removing the medial arthroplasty and converting into a primary total knee is going to be less hassle-some and is going to be associated with less complications as compared to taking the total knee out and doing the revision. So it's all about preserving the bone stock and doing the right decision at the right time. But I feel for Dr. Faiz, because we do see, it's not only you, we also see these patients. And you sometimes think, yeah, as an orthopedic surgeon, what can I offer? You feel sometimes helpless. So I would urge you to, assess the detail of the symptoms, and you would be able to, I can tell you, you would be able to find out a specific reason for the aggressive pain, and then you can address it with other options rather than thinking of a primary knee arthroplasty.
Since I'm not an arthroplasty surgeon myself, so I have one reader's concern, and I'll direct my question to Dr. Hussain. So you mentioned in your presentation that one of the factors, apart from infection and all this wear and tear of the materials, is the age of the patient. If the patient gets a total knee at a younger age, eventually, because there is greater use, so the chances for revision are more. So what was the age range in your study for your patients? And also, what do you think was the longest period after which revision had to be made? You have to unmute yourself.
Yeah. The age was 60 plus minus 6. So the minimum age in that age group was 55 years. And we did not specifically isolated the groups in younger and older age groups. Sorry, what was your second question?
I was saying that after how many years, like maybe 5, 6, or 7 years that you had to change the knee? Like what was the longest period after which there was the need to revise?
That was 8 years. In our study, it was 8 years.
Okay. So the maximum was 8 years after which revision had to be done.
Yes.
So maybe it has something to do with the follow-up, because there's a limited follow-up of the patients. So perhaps you can't really say.
Yes, sometimes patients were offered revision total knee arthroplasty, but they were lost to follow up, and then later on, when they were unable to tolerate the pain or unable to do daily activities, then they later on come back for the revision. So as Dr. Mujahid said, there are financial restraints and things like that, which leads to delay in the surgery.
Okay, so thank you very much. So we don't have any questions from the audience as yet. I will request Professor Eid Mohammed, who is the president of Pakistan Orthopedic Association, to kindly give his remarks, and maybe if he has a question, he can put it forward.
Thank you, Madam Maisha. Dr. Hussain, please can you tell me ये जो आप complications बता रहे हैं और आपकी सीरीज में 46% है रिवीजन की, तो इसमें आप क्या करते हैं फिर? 46% अगर इन्फेक्टेड हो जाए तो आप सारा इम्प्लांट्स निकाल देते हैं या फिर वेट करते हैं, निकाल के फिर डाल देते हैं? क्या आप
सर यूजुअली जो रिवीजन से पहले जो इन्फेक्टेड केसेस होते हैं उनका तो टिपिकल जो तरीका था हमारा कि इम्प्लांट रिमूव करके फिर एंटीबायोटिक स्पेसर डाल के और फिर उसके बाद जब सब कुछ नेगेटिव हो जाए बायोमेडिकल मार्कर्स और क्लिनिकली उसके बाद ऑपरेट कर देते हैं. लेकिन अगर कोई भी केस इन्फेक्ट हो जाए तो वी आल्सो टेक इन्फेक्शियस डिजीज ऑन बोर्ड एंड वी डू कल्चर्स डायरेक्टली, ऑब्वियसली रिमूव नहीं करते इम्प्लांट.
Thank you, madam. Thank you very much, Dr. Hussain, and thank you, Dr. Faiz, for the continuation of this healthy activity, and Madam Aisha for your kindness. और
Thank you.
मैं सब लोगों को मुबारकबाद देता हूँ कि ये एक्टिविटी जारी रखने के लिए. I am very thankful to you. Thank you very much.
Thank you, sir.
Dr. Aisha, I've got a question, please.
Ji, sure, sir.
It's from Dr. Wahab. Wahab, you have mentioned about the revision rate in your patients. The etiology I would refer to. On the top it was infection, and second was the aseptic loosening. Did you have any access to the documents or to the record which would tell us what was the reason for aseptic loosening? Like as you have said, as you mentioned in your article, that and everybody knows it, and it's for the juniors, that polyethylene wear, mechanical loosening, malalignment, any underlying disease, obesity, etc. Do you have any clue or any data that in your series which were the most common causes of aseptic loosening? And the other question, why in your series the overwhelming majority of female patients who underwent total revision knee? Thank you.
Sir, I don't know exact reason why majority of the patients were female, but they were the most common in our population, which we studied. And aseptic loosening, in most of the cases, there was significant bone loss in our studies. Polyethylene wear was not very common in our series.
Maybe मुझे रीजन क्योंकि ऑर्थोपेडिक्स में खवातीन बहुत कम है ना होने के बराबर, तो एटलीस्ट उनकी कंट्रीब्यूशन एज अ पेशेंट तो है. सो दिस इज आई थिंक वन ऑफ द रीजंस के इनकी स्टडी में, और मे बी द मेन वर वेरी नाइस इनफ टू स्पॉन्सर द वुमेन इन देयर फैमिली. एंड मुझे जनरली लगता है कि जो डिजेनरेटिव आर्थराइटिस है वो उसकी वैसे भी प्रेवलेंस अगर हम ओवरऑल पाकिस्तान में देखें, वो आई एम श्योर या आर्थोप्लास्टी फोरम के लोग ज्यादा अच्छा बता सकते हैं, वो ज्यादा फीमेल्स में है, एंड दैट इज बिकॉज ऑफ द पुअर लाइफस्टाइल एंड द लाइफ चॉइसेस वी मेक. So if it
have got more knee arthritis.
Exactly. So then the men in the family have the pressure to get the joints replaced. Okay, so thank you very much everyone for this very, very healthy discussion and for your kind contribution. Today, unfortunately, we had a bad news yesterday about the sad demise of Professor Saeed Minhas. And we all know him as our very, very beloved professor, teacher, and an author of many wonderful books. Professor Saeed Minhas remained a professor of Jinnah Postgraduate Medical Institute and Sindh Medical University, Karachi Trauma and Orthopedic Center for many years. And unfortunately, after a very severe accident for the last 2 years, he was not well, and yesterday we lost him. So I will just request everyone in the audience to make a quick prayer for him. Maybe Saad can recite Surah Fatiha quickly, and then we can all, pray for his maghfirat.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم قل هو الله أحد الله الصمد لم يلد ولم يولد ولم يكن له كفوا أحد الحمد لله رب العالمين الرحمن الرحيم مالك يوم الدين إياك نعبد وإياك نستعين اهدنا الصراط المستقيم صراط الذين أنعمت عليهم غير المغضوب عليهم ولا الضالين.
So may Allah bless his soul in eternal peace, और हम सब की बहुत ज़्यादा दुआएं और best wishes हैं उनकी family के साथ. So with this, we end today's session. Thank you again for your participation, and inshallah, in the next month, we will come up with a new article. Thank you.
Thank you.
And
Allah
Khuda
Hafiz.
Hafiz. Khuda Hafiz.
Hafiz.